Well, hello there, everyone, and welcome. On behalf of Abbott, we want to thank you for taking time to attend today's program. This is Aspire Analysis Results and Best Practice Recommendations, presented by Dr. Jennifer Cowger and by Sarah Shettle. They are both the lead authors of the Aspire Study's recent publication in JHLT. A few disclaimers for all of us as we get started here. The content in this presentation does represent the beliefs of the speakers and does not necessarily reflect the views of Abbott. Information today presented is consistent with applicable FDA guidelines. This content reflects the speaker's experience. The applicability of this experience should be considered in the context of your individual centers and patients' needs. The speakers are presenting at the request and on behalf of Abbott, and an honoraria is being provided. This meeting is not intended for CEU credits, and again, support for this program provided today by Abbott. Our featured speakers, my pleasure to introduce both of them to you. Jennifer Cowger is here. Dr. Cowger is the section head of advanced heart failure at Henry Ford Health, specializing in severe heart failure. She leads care for patients receiving advanced therapies, including LVADs and heart transplantation. Glad to have her on board. Joined by Sarah Shettle. Sarah is a physician assistant, ventricular assist device coordinator in the Department of Cardiovascular Surgery at Mayo Clinic in Rochester, Minnesota. She is also an assistant professor of surgery in the Mayo Clinic College of Medicine and Science. Want to remind all of you again that we do have the ability to take in your questions and comments, so share those with us at any time here today. With that, Sarah, my pleasure to turn things over to you. Brief agenda, and then we'll dive into the content.
Well, thank you all for joining. I just am so appreciative that there's so many individuals that are interested in helping to learn a little bit more about what are some best practices that we can implement for our patients. So we'll be spending some time today talking about the importance of driveline management. We'll go through the Aspire analysis specifically with regard to methods and implementation. Dr. Carter will be sharing the results and conclusions of our study. And then we'll conclude with some best practice guidelines and some summary recommendations. And of course, open it up to you all for feedback and for thoughts because we want this to be interactive for everyone. So with that, I will delve right in and start with a little bit of background that probably is familiar to a lot of you. So as many of us know, centrifugal flow devices like the HeartMate 3 LVAD are superior to axial flow devices when it comes to mortality advantages. And if you look at this graph here on the left, you can see that centrifugal flow technology extends survival approaching 60% by the 5-year marker, which is a huge improvement on previous technologies. But as a lot of us know, mortality is one thing, but it's another thing for patients to actually have improvements just to their overall quality of life and how they do with device therapy. So importantly, in functional status improves with HeartMate 3 support. In fact, NYHA class 2 to 3 can be achieved by more than 2/3 of patients with a greater than 200-meter walk distance improvement to the 6-minute walk. So I think those are important factors for us to consider when it comes to patients. So we know patients can live longer and they have improvements to functional status. But one of the things that can be an Achilles heel to LVAD therapy is just the underlying LVAD infections that patients can experience that can certainly impact their long-term success. I think many of us have experienced a patient or two that have had a driveline that presents similar to that image in the lower left corner. And then, of course, the subsequent sequelae that result. And so if you look at the graph there, the figure in the left-hand side of the screen, you'll see some lines in green. The line in solid green represents one major infection, and the dashed lines represent 2 or more major infections. So you can see the clear increase in mortality and how this is associated with time on LVAD support. And if you look at the table here on the right-hand side, you can see that clinical events within 1 or 3 years on LVAD support are definitely impacted by infection. In fact, the hazard for mortality increases from 10 to 19% when patients are supported for 1 or 3 years with each infection episode. So I think we can all appreciate this, and just based on our clinical experience, that infections are certainly something that impact a lot of our patient population. And we would like very much to identify strategies that could improve their outcomes with infection or to minimize the risks of infection from the beginning. And so with that, this graph represents some of the top performers. So if we look at that blue line at the top, this represents groups that are in the top 10 percentile, or that are better than about 90% of centers. The red line represents patients from sites between the 10th to 90th percentile. And then group 3 in the green below are patients that are in that lower 10%. And of course, we would all like to be at that 10%, that upper 10% marker. So our hope in doing a study like this was to take centers that maybe are in that 10 to 90 percentile and move them into that upper 10 percentile. Now, the question is, how do we do this? What are these centers that represent this kind of blue line at the top? What are they doing, perhaps, that centers that are maybe red or green aren't doing? Or what are centers that are red and green doing, perhaps, that maybe we should avoid doing to improve our overall approaches to infection in this patient population? So there have been a variety of different quality improvement initiatives that you can see listed here that have attempted to better define and offer us approaches to improve infections in LVAD patients. We were hopeful in our study to better understand some of the variability in patient management. Those of you on this call here will know that there's huge variability in the types of dressing kits that are utilized for LVAD patients, the frequency of those changes, the types of devices used to immobilize the driveline, whether or not patients are allowed to shower, what might imaging monitoring look like, is a wound vac used, and numerous other strategies that have been implemented to try to improve infection management. But what isn't known is which of these things are helpful or which may not matter or which may actually be harmful to patients. So Dr. Kanwar and Dr. Kauger had previously published a really important study that talked about the fact that there is variability in clinical outcomes with HeartMate 3 LVAD patients. So if you look at that figure on the left, you can see that there is variability in center-adjusted mortality at 2 years, with some centers having very low mortality and other centers having higher mortality. And then if you look at that figure on the right with the colors green, gray, and red, you can see that there are some centers that early on perhaps start out, maybe in that bottom 25th percentile and improve to that top 25th percentile by late support period, or some centers that start out perhaps doing well and then decline over time to that, perhaps bottom 25th percentile, and some centers that stay at that top 25th percentile throughout the continuum of LVAD patient support. So what isn't known is what are the factors that are driving that top 25th percentile outcome. And we know that it exists, that there's variability in these, but what isn't known is what are the factors that implement or that can cause some of that variability. So this table here represents overall outcomes for Momentum trial. And if you look in the 3 different breakdowns within this, you can see an early support period, which is represented by the first 3 months of support, then the late support period, and then overall support. So if you look at the early support period highlighted in yellow and represented by the arrow, you can see that there are some centers in that top 25th percentile that don't have driveline infection at all. And then, of course, the further along down the percentile you go, more driveline infections ensue. If you look at the late support period, which is the 91 days to 2 years, you can see that centers in that top 25th percentile have half of the infections compared to those in the 75th percentile. And if you look at the overall support period from 0 to 2 years, that same trend holds, that those centers in the top 25th percentile have nearly half of the infections compared to those in the bottom 25th percentile. So the question is, how do we move to reflect outcomes of those centers in that top percentile? And that is what led us to do this ASPIRE study. So ASPIRE stands for Assessing Site-Specific Patterns of LVAD Patient Management Leading to Exemplary Outcomes with HeartMate 3. This, importantly, was a patient-centered, research-based study. And I know many individuals on here would say that they are a VAD coordinator or a VAD nurse. And this was truly a multidisciplinary approach to undertake this study. And we know from Dr. Kauger and Dr. Kanwar's work that there is variability in outcomes. What we were hopeful during this study was to discover, where does that variability in management lie? And this is where we were able to leverage all of the different responses from the VAD coordinators that graciously participated in this study to help us understand what their management practices were. And ultimately, our goal was to align these variabilities in management practices with known outcomes to identify what are the best practices that we can do to improve the patient care of patients supported with HeartMate 3 LVADs. So the Aspire methodology involved coordinators at 30 of the 69 Momentum centers. These were randomly selected, and these coordinators graciously involved probably 2 to 3 hours per each coordinator, sometimes even more, to really share what were some of the in-depth practice management strategies that are done by their centers in order to be able to work to target improvements to infection. Now, what was not known is whether these were tied to improved outcomes or worsening outcomes, and we'll get to that in just a minute. So there were 79 different infection-related questions that were asked of these coordinators, ranging from topics including antibiotic utilization, diabetic management, and a variety of questions surrounding driveline care. And then these were sorted into standard intensity or high intensity responses. For example, daily dressing changes would represent a high intensity practice, and every other day or weekly dressing changes would be standard intensity, for example. What was done then was we were able to take the results from these surveys and we were able to pair them with STS Intermax data showing outcomes in patient population. And so essentially what we were able to do was say, what are the different variability in practices that we see? And then how does that align with known outcomes? So let's suppose a center has, really great outcomes. Are there practices that align with those really great outcomes? Or are there practices that align with perhaps suboptimal outcomes that we can pull out to identify things that we should ideally try to do or things that we should try to avoid to improve infection risk in this patient population? We used STS Intermax definitions for infection to adhere to standard definitions, and we identified early infections as those less than 90 days and late infection as those greater than 90 days. And we're able to partner with Pearso to be able to do Cox proportional hazard modeling to identify what some of these practices were that we'll talk about in a little bit. So in summary, our statistical approach was basically to do this Aspire survey, to define practices, and to assess where does variability lie amongst these practices. Then we were able to take the different practices and match them to known STS outcomes. And then we were able to match those along with prior publications by Dr. Calgar, Dr. Kanwar, and several others in the field, including standards that we all know and utilize to currently manage patients, and meld those all together and say, what are some best practice recommendations that we can take to hopefully improve the care of these patients? For those of you who are interested, these are all the different 30 centers that were involved in the Aspire study. Again, these were randomly selected centers that you can see span the country. So thank you very much if you were a coordinator who was one of these participating centers. Research like this wouldn't have been possible if it wasn't for your involvement and your willingness to share practices. So thank you to all who participated. And with that, I will turn it over to Dr. Calgar for our much anticipated results and recommendations.
Awesome. Thank you, Sarah. And thank you to the 200 and some people who have joined us. Much appreciated. Just a housekeeping. I know the Joint Commission loves proof of attendance at VAD related education. So if you're on this for 45 minutes, at the end, you can download a certificate so that when the Joint Commission comes through, your program director can show that you've had your education for the year. And we'll show you that at the end. So looking back at Aspire, first thing to look at is of the centers, we looked at freedom from first VAD infection. So this is VAD related infections. These aren't the UTIs, the pneumonias, and the post-op setting. We're really focusing on VAD infection stuff. So 87% at 1 year, or 13% had an infection by 1 year. And then 78% were infection-free at 2 years. And of these VAD-related infections, unsurprisingly, the vast majority, 90%, were driveline infections. So then of our questions, we asked a few key things. And one, we looked at diabetes care. And in the surgical literature, optimizing blood sugars in the pre-op and post-op really has been shown to have a great impact on infection, specifically mediastinitis, et cetera. So we looked at diabetes practices to see if VAD centers in general that had aggressive preoperative diabetes practices, aiming to get that A1C less than 6.5, having endocrine consult on your patients, did that have a marked impact on infection, VAD-related infections in the post period? And the results are here. And if you see, you look at an unadjusted hazard ratios, and the ratios were not statistically significant in either the early phase or the later infection. Then we looked at perioperative driveline management. So, when did we give antibiotics? Was it 24 hours before, greater than 24 hours before? And how long did we continue antibiotics after a bad implant? And even how many antibiotics or antimicrobials is probably the more important term, because some centers still provide antifungals. And the results are there, both in the early and later period. The timing of antibiotics, nor the number, specifically 2 antibiotics versus, or 2 antimicrobials versus 3 antimicrobials, didn't have a significant impact on outcome. Then there were questions about tunneling of velour. Do you routinely double tunnel the velour? Again, didn't have a significant impact on outcome. And I think we pounded into everybody's heads in the distant years about burying that velour. Get the velour buried, and 100% of centers buried their velour. Okay, so let's look at driveline management. So these, the top up there is a driveline change frequency. What you see on the side is on the inpatient setting, blue is daily. So this is early post-VAD. So within the first 4 weeks, 48% of centers changed the driveline daily. 31% changed them kind of every other day, every few days. And then 21% right out of the bat only changed them weekly. To the right of that is outpatient. So 57%, once patients made it to the outpatient, and this is around 4 weeks, we asked how often are you changing drivelines in the post-VAD outpatient chronic phase? And 57% of patients were shifted to weekly dressings. And again, this is uncomplicated drivelines. These aren't infection concerns. These are just routine management. A third of patients changed them every other day or every few days. And there are still 10% of centers, numbers were small, but that still did daily driveline dressings. So those were significant differences. And then we looked and said, all right, what are we using at these centers on driveline kits? So silver impregnated dressings include dressings such as Silverlon, or some of the silver gauze, I think it's called Acticoat. And 41% to 43% are using silver dressings in both the inpatient or outpatient setting. 7 to 13% are using the chlorhexidine biopatch. The green is either or. So they're either using a silver or a chlorhexidine patch. And then the yellow is neither. And neither could be just using 4x4s. Some centers were using Meta Honey. Some centers, small numbers, and small numbers were using iodine. So let's look at the results. So I think the key thing to see here is that if you use chlorhexidine cleanser with a silver dressing, you, on an unadjusted analysis, you halved your driveline infection in the early period, and you had a 40% reduction in the hazard for driveline infection in the later period. Also, what's important is in the later period, if you did less than daily driveline changes, you were less likely to have an infection. So I'll repeat that again. So if in the chronic phase you changed your driveline less than daily, you were less likely to have infection. So that was a favorable intervention for patients. In the short period, a driveline change frequency didn't have a significant impact on infection. It was in that chronic period, that behavior, that had a significant impact on infection. If you just want to look at your simple KM curves and you look at freedom from first infection in those that used silver plus chlorhexidine, which is that kind of lighter blue color, versus all others. So that would just be chlorhexidine alone, or your use of iodine, or a non-silver dressing of your choice. You see this 40% reduction. And if you look here, that curve really is starting to separate around the 6-month mark, and it continues to separate out to 2 years. And I think that in our field is very important, because this isn't an operative effect, right? This is a chronic management effect. And those curves, at least out to 2 years, are continuing to widen, which means that hazard is likely to be very important. If we do a multivariable analysis and we forced in age and we forced in BMI, because we know both of those are correlates of risk, meaning the older you are, the less likely you are to develop a driveline infection. And the larger your BMI, the more likely you are to develop an infection. So we forced those in the analysis based on prior data. And we added in the silver and chlorhexidine cleanser, and we added in what we're calling high intensity dressing frequency, meaning daily dressing changes beyond that period of a driveline incorporation. And we saw a significant impact or benefit on adjusted analysis using the silver chlorhexidine, so the silver dressing, chlorhexidine cleanser, and a significant unfavorable impact from frequent driveline changes during the chronic support period. So after driveline incorporation, if you're still changing your driveline daily, that was associated with increased infection. So the other thing that was really important, and this gets into kind of the voodoo of statistics, if you will, which I love, but not everybody does. But when you do this analysis, we forced in a variable for LVAD center, and we were blinded to the LVAD center, but Curso, who is the DCC or data coordinating center and did our statistics for Intermax, was able to assign center and force that into modeling. Because what we wanted to know is, even though we're controlling for age and BMI and your dressing and how often you're changing dressings, how many center level, how much variability in outcome is related to things that centers are doing that we're not able to measure in this analysis. And what I think is important is it's 20% essentially of the variability of the model is still related to variability that's at the level of the center. So what are the differences at Henry Ford and Mayo and Cleveland and Aurora and all the other centers that are on here that we're doing at a center level that we're not talking about as a community that's contributing to infections? And I think that is what our discussion should be today and going forward for future meetings, and how we can reduce the variability so that we can impact infection. So our recommendations, taking all this together, taking in all the publications from prior studies on infection and variability, and what we've learned from SDS and the surgical data, is what can we start to talk about here and message and communicate as a field? Because let's be honest, randomized controlled trials in the VAD field are very hard to get funded. And unless we start to act like action and get together and talk about, let's agree on these care practices so that we can tease what is beneficial or what is harmful going forward in the future. This is our only way really to elevate the field. So what we found are as follows. From this study, it appears that chlorhexidine and silver-based dressings really have a marked impact on the reduction of especially late infections, and a reduction in early infections on adjusted analyses. Okay, so that's take home point number one. This may be important data if you're a center that struggles with coverage for getting silver dressings. Now you have data to provide to insurers in your institution. The more you manipulate the driveline, or let me rephrase this, the more your patients and or caregivers manipulate the driveline or expose the driveline in that chronic care setting, it appears that we're increasing the risk of infection. And I think this goes back to patients and caregivers aren't nurses, they aren't physicians, and managing a driveline is not, second nature. So maybe now if we keep that driveline that looks to be uninfected covered and change it every other day or once a week, that is less manipulation, less irritation to that driveline, and perhaps maybe that's why we're seeing less driveline infections. And then, we pull from the published data and we look at this and say, okay, let's follow STS guidelines and ISHLT MCS guidelines as it relates to when do we start antibiotics and how long do we continue antibiotics in the post-op setting. The Joint Commission, as we all know, when they come in to survey this, they love to look at timing of antibiotic administration in the OR and pay attention to how long we're giving antibiotics. As we look and see the size of our programs and the number of patients that we're seeing, we have to have a way to communicate between providers what drive lines look like. Does it always look a little bit red, especially in fair-skinned patients? That drive line can look red and not be infected, right? So let's take a photo, let's put it in the chart, and let's use common language to stage these drive lines so that we are speaking a language between providers that we can carry on and identify those drive lines that are struggling. And then I think that this is an opportunity to talk about education. Are you providing education after VAD implant and that's it? You're done? Are you bringing your patients and families back at 6 months and at 1 year and at 3 years and saying, hey, show me how you change the drive line? You can do this in clinic because caregivers change, patients do it on their own. They watch, various videos and learn from other people, and they are probably doing things that you don't want them to do. So here's an opportunity to rein in and make sure that your patients are managing that drive line in the way that you want them to. So what are our hopeful tactics for the Aspire? You guys answered wonderful sets of questions, and we have more data to present in terms of stroke and other things. But really, as Aspire, it's getting messaging, it's talking, it's communicating, understanding which programs are having higher than average outcomes and what we can learn from these programs. We want to engage the coordinators, we want to engage the clinicians, we want to engage the NPs and the PAs into discussions of what's working for you, what is not working for you, how can we all come together and do something similar in small ways so that we can understand data when they come out of clinical trials. We want to align with heart failure teams and administrators to explain why we need a certain drive lines or why we think certain ratios for care may provide better outcomes. We want to work on developing best practices. And in this setting, I was careful to use the term best practice, right? Because we aren't at guideline level of evidence with clinical studies, but we as a field need to start talking about what we're going to agree on as best practice, very similar to bearing the velour, so that we can continue to move the field forward. With this, it's hopeful that we'll enhance outcomes and, very importantly, continue to energize the LVAD community. And I think from your end, especially with the number of VAD coordinators to see on here, this is your opportunity really to help with that energizing, right? You're with these patients day in and day out. You know the intricacies of family support and patients that may be struggling on some aspects of the VAD management. And this is where I think Sarah and I and the others that are working with Abbott and Aspire would love to hear your thoughts so that we can continue to boost the field forward. And with that, we'll open it up to questions. Questions are, please type them in. Don't be shy. We appreciate any and all questions, and no question certainly is too simple. So maybe, Sarah, if you don't mind, while people are typing in their questions, as you think about this, from the standpoint of the coordinators, and I really do think that when it comes to driveline success, the VAD coordinators are just really at the apex of the education and the success here, because this is, you know, the amount of time that you guys spend with patients and champion patients and families through. What do you think are the next steps for coordinators at a community in the community to make an impact from this data?
Sure. Well, thank you for that question, Dr. Kelger. I think that the data that we were able to show here today is, I think, some of the first data that really ties silver dressings to outcomes of infection and improvements in risk. And so if we look at all of the different centers across the country, there are over 100 different dressing change kits, over 100. And I think that that speaks to the fact that coordinators and hospitals are trying to come up with, like, what's the best combination or cocktail of items to improve infection. And now we have data to support what that could include. And so I think we have data now to show that silver will help. So I'm really excited to be able to use publications if there's any question about coverage, and to use that for administrators if they're wondering about costs or things, because I know sometimes it comes down to a cost. And so if we can show data as to why something is better, and earlier in this presentation, we were able to show clear risks with mortality outcomes with infection. So I think it's exciting to have data to be able to build kits that actually will be helpful in improving infection risk for patients, and also just knowing what are frequencies of changes that would be helpful to do, because I think that was a question that wasn't fully answered either. So I think that those are two things, for me at least, that we're able to implement, but I know that others probably will have other takeaways, you know, depending on what their centers, you know, might be struggling with here. So I don't know if you want to go through any of the other questions, but hopefully some of this information has been helpful in implementing new practice changes.
Yeah, I think what's interesting is, and partially this is why I love the field, we are a bit of the wild, wild west at times, right? And again, it's because clinical trials are hard to support in our field. Mm-hmm. And I've moved from a couple, you know, from various institutions, and it is very different how we manage patients from center to center. And I think we're starting to see some really great questions pop through. And this, I think, is going to highlight that. So maybe we'll take one of these questions. Let's see. There was one question about, did we evaluate silver dressing? And I'm not supporting a company, so I'm going to use Silver Lawn, because that is the only actual silver dressing that I know, versus what I call the Acticoat, that silver gauze that other centers or centers also can use as a antimicrobial. So I know the answer to this, but maybe I'll have you answer that, Sarah.
Sure. Yes. Well, we did not use branding in any of the questions. We just said, you know, were silver-based dressings used, and coordinators could say yes or no. So I actually couldn't tell you which of the two, because we intentionally left it unbranded to allow people to choose options that would work best for them and whatever DME options they can work with. But yes, that's the one that I'm familiar with, but it may be, and again, this study was US centric, and I saw there was a question down there, you know, how does this apply internationally? So we did not do the same set of questions, let's say, in Spain or in Germany or other countries. So they may have different, you know, formulations that could be done, but I can't speak to which of those options necessarily would be available overseas.
Yeah, and I'm not a microbiologist. The argument is that silver is the anti-infective. This wasn't a big enough cohort to really be able to dive down to the nitty gritty on, was this a Silver Lawn versus the saline activated, the wet, what I call Acticoat dressing. So we weren't able to get that specific in the analysis, but the thought is maybe that silver is the antimicrobial. And then somebody asked about chlorhexidine with or without alcohol. And I have learned a lot about chlorhexidine as a non-surgeon. And we all see patients who have dermatitis from chlorhexidine or from the clear windows or tape, right? So dermatitis is different from cellulitis or infection because it's you're having a reaction to the substance. Chlorhexidine comes in various formulas. There's the chlorhexidine that they use in the OR that's really concentrated, meant to be antimicrobial. You leave it on, and then after certain minutes, they move forward. And then there's more dilute chlorhexidine. There are plenty of studies out there of the sensitivities, especially to concentrated chlorhexidine. And we see this, right? We see patients that get red, beefy, angry, irritated drive lines from chlorhexidine. And in fact, I'm one that during COVID, my own wedding ring, I got stuck under my ring and I had to get my ring cut off because of just the irritation from chlorhexidine. So if you're having a lot of chlorhexidine reactions, my first thought would be look at what formulation of chlorhexidine you're using. And there are just going to be patients for your little chlorhexidine wand that are not going to be able to tolerate chlorhexidine. And in fact, there are patients out there that may not tolerate silver, but the general take in my mind, and Sarah, you can give your input as well, is these are just kind of general discussions. There's always going to be the one-off, two-off patient that may have intolerances.
Yes, I absolutely would echo what you're saying. And I think sometimes even just the concentrations of these that are used can be a little aggressive, so to your point, make sure you're reading the labeling on the type that you're using. And I also saw in the questions, Dr. Calvert asked whether there were any surgical recommendations. And I wondered if you wanted to maybe touch on antibiotics, because I don't believe that this bore out that double tunneling, for example, or timing for suture really impacted infection, though I'm not certain that it was powered to do that.
Yeah, so the double tunneling certainly was not powered. I was amazed at the variability in tunneling across the U.S. And the saying is you do where you were trained, right? So if you're trained at Cleveland and you move to Henry Ford, and that's our surgeons, they do what our surgeons all came from Cleveland, and whatever they trained and learned in Cleveland, that's what we do here because it works, right? I think that's going to be similar across. So we were unable for tunneling to really come up with anything helpful. There have been a lot of studies on antibiotic utilization, and STS has and ISHLT MCS guidelines have recommendations on antimicrobial coverage. In general, antifungal coverage is not felt to be necessary. And many centers have pulled back on the antimicrobial, and the recommendations are you cover staph and you use the antimicrobial that matches your local antibiotic profile. And it sounds crazy, but different levels of MRSA, MSSA, et cetera, are going to be present in different parts of the country. So the guidelines are written to cover those skin bugs and making sure that you're taking into account your local flora. And there really is no, in the surgical literature, we didn't look at this here, but this is where we pull from other data. There is no benefit to keeping those antibiotics going long-term just because you have chest tubes in, right? That used to be when I was training. We used to keep antibiotics going back in the old days until chest tubes were out. And then, STS and others did studies showing that really there was no benefit to that prophylaxis. And in fact, to tell you how old I am, we used to keep antibiotics going for at least 90 days after VAD implant to prevent driveline infections. So it was often doxy back in the old days. And certainly we're not doing that anymore. Okay. Do you see anybody using betadine in place of chlorhexidine for skin sensitivity issues? Do you want to take that one, Sarah?
Sure. So this study wasn't designed, nor did we really ask about what centers were doing for patients, that fall off from kind of the standard of care. So whether they had, infected drivelines, what was the frequency of changes, or if they had sensitive skin, what was their frequency. But yes, I can tell you that centers will use that. I've heard some centers use VASH or a variety of other different gentler soaps or agents to help for patients that maybe do have some skin sensitivity. So we didn't intentionally, this was not really designed to study that, so we don't have enough data to show which is the very best agent for skin sensitivity. So I will tell you that there's been success with each of those other agents.
Yeah, and I think as coordinators, you guys try. Sometimes, I don't know, I see some of my coordinators on here. They'll, you'll see the caregiver that like puts a ton of chlorhexidine on. And, sometimes we'll get these little sterile saline, like pink things and say, okay, make sure that you're really trying to get that chlorhexidine off the skin and not just leaving, like you'll see like layers of chlorhexidine on, and just educate them that more is not always better when it comes to chlorhexidine. Certainly you need it to be there and be on the skin, but for that really thick stuff that sometimes is the only thing available in the kit, using saline to get that off is good. If that doesn't work, there are patients absolutely out there that need to paint on the chlorhexidine. And in that setting, if you can't tolerate, or need to paint on the iodine, in that setting, if you can't tolerate chlorhexidine, that's okay. You just can't tolerate it. And the same goes with the windows. There's gentle windows out there and various barriers.
Mm-hmm. And to your point, Dr. Fowler, and maybe this lends into a couple of the other questions there was discussion about showering and how does that play into everything. And certainly we did ask within this survey, are patients allowed to shower? How soon can they shower? Do they shower at the hospital? Do they shower after discharge? I will tell you also that the frequency of patient showering for those who do also highly varies after discharge. So it wasn't like all patients are showering daily or all patients are showering weekly. But essentially, from my perspective, and this wasn't, powered enough to say what frequency of dressing changes should be after that, but because I'm not always entirely confident that my patients are doing a perfect job on site care, I always tell them to do site care after they shower. Most of my patients, particularly those who are older, are not doing showers daily. They're showering, a couple times a week, which typically coincides well with their dressing changes. And so I always tell them shower first and then site care after, in the event that they do have some water that seeps in, then at least they're cleaning that area thereafter. I don't know if you have other thoughts or perspectives.
Oh, my coordinators on here are probably laughing. I am very anti-shower in general.
Yeah.
Yeah, and I could, just because anytime you get serratia and pseudomonas, you're done. Like clearing that infection is darn near impossible. So does that mean our patients can't shower at all? No, like we usually say, get yourself one of those hand sprays and, have a significant other spray your back and spray, your bottom half. But I cringe at the thought of water going over their head and down their body. But that's just me. I don't have any evidence base for that, other than to say I really don't like gram-negative infections. So what my patients do at home versus what we recommend they do, we all know is its own thing as well. And that's where every time I'm in clinic, I ask, do you shower? Just please be honest, because I would rather know and make sure that they're educated and understand that, okay, they're going to shower. This is important to them for quality of life. Let's make sure that they're doing all the appropriate precautions to get this done. Somebody asked about, did we look at chlorhexidine impregnated gauze versus silver, because their center, probably because of cost, is replacing the silver patch. And I will say that we in my prior center were the chlorhexidine patch centers. And what I mean by that, let's see if I can push this through. No, that's not it. Okay, it was removed. I had a picture of a little round chlorhexidine disc that we used to use at our center, and I will just say that that was absolutely the group. So the group here was either you use the chlorhexidine wand, that a dressing, or you used a chlorhexidine disc with the dressing over that. So that was our chlorhexidine group versus the silver group, in terms of what I consider as a bio patch. I find chlorhexidine to be caustic. There are certain groups of people, especially fair-skinned, that are really irritated by chronic exposure to chlorhexidine. There is a ton of published data on this in other literatures. Like, you'll read about it from dermatology, etc. So just be cautious about your chlorhexidine. It's excellent at being an antimicrobial, but it loves to be caustic in certain people to the skin. And then if cost is an issue, one of my VAD coordinators, they're so awesome. There's always a way to negotiate costs of things, and somehow we negotiated our cost to be cheaper with silver dressings than the chlorhexidine biodisc. In America, everything's up for negotiation when it comes to buying things in bulk. And the data for some of these silver-based dressings for other things like plastic surgery uses them. Some centers use them at chest tube sites. Some centers are using them at central line sites to reduce catheter-associated infections. So everything is always up for negotiation. Let's see, some other questions. Did any of our patients have a driveline infection prior to the study? So the questions were based at, in general, for uncomplicated drivelines, what is your treatment for patients? So the survey was addressing center practices in uncomplicated drivelines. Now, when we looked at, of the Momentum 3 centers, and we looked at their Intermax data, we looked at, okay, if you use chlorhexidine, what frequency of infections happened at your center? So this was all the patients on HeartMate 3, which I think would go back to 2017, 2018. Don't quote me if I'm wrong, when it first got FDA approval. And your first onset of driveline infection from this point. So hopefully, Jessica, that answers your question there. Do you want to take the next one, Sarah?
Sure. Yeah, I saw a question in here that asked, whether it was patients that were doing dressing changes in the hospital or the hospital providers, and then whether maybe there may be an increase in infection risk there. And I think this absolutely goes to your point that you made earlier, Dr. Kauger. How often are we educating patients, and really, what does their site care practice look like compared to, let's say, a VAD coordinator or somebody else who's doing it? And so, so in the hospital, we did not say, is it the patient or is it the coordinator that's doing the dressing change, or is it the patient or is it the caregiver? But I do agree that if patients or caregivers aren't using right technique, it certainly will increase their risk. So I think, if anything, this speaks to the importance of good education, re-education, and bringing patients in at regular intervals on the post side to make sure that site care is done well, because patients, I think, are doing their best but may forget things or pick up other practices that may not necessarily be terribly helpful. In the hospital, as much as possible, ensuring great site care, especially in the early period, to allow for good integration before discharge, is extraordinarily helpful. And if a patient or caregiver isn't able to do that well, I would encourage ongoing and re-education until they're able to do that successfully before handing that off to them, just to minimize infection risk.
Yeah, and I think, chlorhexidine, and I'm not anti-chlorhexidine, but it's that thicker goo, right? So you clean off the driveline, and it has a little gummy feel to it, and as your skin sloughs off, right, you can get what I call the crusties. There's no medical term for this, but the little like crusties around the driveline. That doesn't mean it's infected, right? It's just the sticky chlorhexidines grabbing onto skin and other stuff. there are times when patients or caregivers see that, and we all know this, you dig at the driveline, and what was a relatively reasonably incorporated driveline has now just become irritated. So I think this is where, when we talk about quality assessment, performance improvement, it's not only within our center, it's with our patients. And, when they try to do well and they mean well, but just educating on, trauma is its own risk factor for infection.
And furthermore, Dr. Calgar, there was a question there that talked about sutures and whether they were helpful. And because I think it was nearly everyone in the study had applied sutures, it wasn't something that we would recommend to continue to do that, because basically everybody is placing a suture, that it wasn't something you could pull out to say mattered, because it was done at all the centers.
Yeah, I call them stay sutures. They're usually, most centers remove them when they either irritate the patient or, within, I don't know, we remove ours within a week or so. Somebody had their couple weeks, but you're right. We couldn't look at some of these things like velour just because everybody does it. There was a question about silver fresh out of the OR. We did move to that, and you certainly can. I think the thing to know about silver is it's not going to be as absorbable as a 4x4, right? So if you've got skin edema, ascites, drainage, right? So once you get an infection, you're not going to sop up the goo as well with silver. So even though it's antimicrobial, you need to be able to keep your driveline dressing dry. So this is where you need to look at the site as coordinators. We really rely, and our coordinators look in clinic and say, nope, you're still too moist for silver after your infection. Stay with, the 4x4s. And then this will also hit on another is, once the infection's clear, what do we do? Well, we don't know. And we don't have data for this, right? I can tell you what our center does is once they're dry, no evidence of infection, we go back to silver, but I can't guarantee without any data to say that that's the right thing to do. I will say we use it fresh out of the OR, and the centers that used silver, many of them used it fresh out of the OR, but we just don't have the granularity to be able to look at that.
Yeah, we do as well. And it looks like in there, Dr. Calgar, there are some questions about how do we implement this? I'm assuming this is probably from a VAD coordinator, like how do I take this to my center, or how do I implement some of these findings? And so for those of us who are on here who are like, gosh, I'm a VAD coordinator, this sounds great. I love the idea of incorporating silver or making some changes to this. As a physician, what would be meaningful for you to hear if somebody was going to present this, let's say, to their, their chair or their, VAD physician lead to implement something like this? Or how might approaching administration go with findings from this study?
Yeah, so, two things is one, we actually want to look at this, do what we call a pragmatic study, which is a fancy word for a trial, ideally using Intermax, where we do silver dressings and then everybody else does standard of care. We just compare our data to that. So if you're interested, email me, jcalgar1@hfhs.org. But aside from that, this is where we as a field, and I beg everybody that we have to start coming up with some baseline level of care so that when trials are published, we can start to understand interventions such as infection and bleeding and all these things that we are all doing differently. We have to have some care standard that we agree on. And we all hear, well, no, that I want to do it this way. But the problem is that we're never going to move the field forward if we can't even agree on a driveline regimen to manage our patients with. So how do we take this back? We say, listen, we learned best practices. They did a study and they looked that silver had over 50% reduction in infection. And how many times are you guys seeing your patients admitted to the hospital? They're here with PICC lines. They're taking up beds. They're getting readmitted with infections. We don't have a great cure, meaning you can do a VAD exchange, but infections tend to come back. if you can propose this as maybe we can reduce 1 to 5 infections a year, right? But that's still opening up beds. It's a quality metric. And you can even take your infections and compare your infection frequency 2 years from now. If you start silver and you say, okay, let's look 2 years from now, frequency of VAD infections, and compare it to prior, to see if you're actually, making impact. And that would be my way to propose it, is that the field is trying to come with a consensus. We are seeing data that has not just a small magnitude of impact, but it's actually a pretty good magnitude. Let's try this and let's work with it. We're not going to ignore data going forward. You follow your data within your center, make sure no harm is being done. And as long as everything's going, then we as a field are working together to move the field forward. All right. I think we have time for a few more questions. Please repeat the email again. All right. J as in Jack, Cowger, COW, G as in girl, ER, at H as in Henry, F as in Frank, H as in Henry, S as in Sam.org. J Cowger 1. I think I left the 1 out of there. Do you have any experience placing wound vacs? All right, Sarah, I know that's tends to be a big thing.
Yeah, so this was something we asked if did centers use wound vacs, but so few centers use them that it didn't arise to a high enough level of significance to say one way or the other. If that's something you're interested in exploring, you're welcome to reach out to me. My email is shuttle.sarah@mayo.edu, and I can share with you some centers that are doing that. But we weren't able to get enough centers that said that they did this to get statistically significant data to say that it helped or not.
I do think that it's not a bad idea. Most infections of the driveline occur later, right? So if this was an infection that occurred within the first 4 weeks, I think that's where the wound vac would have a big impact, maybe promoting granulation quicker, reducing moisture and infection development. But for the most part, the hazard for infection, the greatest hazard, is going to be, after that post-op period, where in the early post-op period, it's the non-VAD infections that get our patients, right? The pneumonias, the bacteremias, the UTIs. I'm not against wound vacs, but if you just look at the hazard for how and when infections develop, I would suspect that impact is probably not as high, albeit I doubt that it's harmful, and maybe they incorporate wounds quicker. I don't know.
Yeah, and to that point, Dr. Cowger, I think that the wound vac, to your point earlier, does help, but it was like greater than 75% of the driveline infections coordinators tied to a tug or manipulation of the site. Yep. So by the time that tug is happening, the wound vac is likely no longer in place. I think that there is another question here about anchoring devices. We did ask if sites used anchoring devices. We didn't specify which one, but there are a couple of really good publications out there that talk about making sure that you have kind of a 90-degree angle, so the line of the drive line plus the anchor and the controller is not directly in a line that you're essentially adding more torque onto the site, but rather angling it at about 90 degrees. And there's a couple of great publications that talk about what are some better anchoring devices than others that use kind of company-specific names. So I believe there are some good references for that. I'm happy to share those with anyone who's interested.
And then the last question, I think, is a great question. Can you discuss the effect of variation in practice within a given site? So that was that 20% variation within a practice that contributes to infection. And I think that's a huge take-home message. And when you talk about quality and how you're going to assess your fields, your centers' performance, it's that variation. So this surgeon double tunnels the drive line. This surgeon uses beads. This surgeon wants silver. This surgeon doesn't want silver and wants chlorhexidine. This cardiologist still wants to keep aspirin, but this one follows Aries, right? So it's all the variation in every aspect of practice that's even beyond, a discussion of infection today, that is a problem, right? So how do you interpret data within your program if surgeons, cardiologists, coordinators, and patients are all doing something different? And that's part of QAPI, quality assessment performance improvement, is you have to have some basic level of a recipe that we're all going to agree to do this. We may not like it, we may not agree, but we're going to agree to do this, so that when something arises, we can say, oh, okay, we were doing this with pulling out our mediastinal chest tubes on post-op day X, or when drainage was Y, and we started to see less pericardial effusion. Boom, that's a check, that's a win. Or no, we saw more pericardial effusion. Boom, that's not a win. So the only way for programs to really advance is to have some level of standard, and that's not easy to do. But your leaders of your programs really are going to want to have the basics down so that you can interpret your data. I think we're at
all right. Well,
right?
With that, we do want to thank you both on behalf of Abbott for taking time to join us, to share your insights, as well as giving the care to the audience and addressing all those questions. And to our audience out there, we also want to thank you all for taking time to join us and being here today.